Hello everyone, my name is Melissa Grundy and I work as an Admiral Nurse at the University Hospitals of Leicester. I'm really pleased to be here talking to you today. I will be focusing on delirium and dementia in the hospital setting. This will range from looking at some of the issues and difficulties a person living with dementia may have, what we need to be aware of and to consider, and how we can support and identify delirium in this group of people when they are in hospital. So the aim of the session is to increase your understanding and symptoms and differences between dementia and delirium. The objectives are to recognise the differences between delirium and dementia and how to distinguish between both, contributing factors and underlying causes, treatment and prevention, assessment tools and management, and apply a structured approach to delirium and dementia using a case study. So what is delirium? Delirium is an acute change in a person's mental state, usually with fluctuating courses over the day. It is characterised by the person becoming more confused than usual. You may notice that they are drowsy or just not their usual self. It has a variety of causes, such as medical problems, such as infections, constipation, dehydration, withdrawal of medications and side effects. In older people, especially with dementia or cognitive impairment, there can be multiple risk factors that contribute to this delirium. So here are some delirium statistics. So the prevalence of delirium in hospital patients is 20 to 30%. And we know patients with a fractured nerve or neck of femur are at higher risk, with 30 to 60% of developing a delirium at some point during their admission. And up to 30% of cases are actually thought to be preventable. Despite this, delirium often goes undiagnosed. 50% of acute hospital delirium patients have an underlying dementia, and 50% of healthy over 65-year-olds who get delirium or admitted to hospital develop a dementia within 2 years. So what are the causes of delirium? So here at UHL, we use the Think Delirium Support tool. Other trusts may use the Pinch Me tool, and this helps to look at potential underlying causes of delirium and general management. So you can see here on this slide, these are the main causes that can cause a delirium, such as, for example, trauma, hypoxia, increased age and frailty, neck of femur fractures, smoke and alcohol withdrawal, medications, new medications that have just recently been started, or side effects and drug interactions. Environment, especially we know in hospital, ward moves, lack of sleep and the sleep reverse cycle. So that's where a patient is mainly awake in the day, awake at night and is asleep in the day. Increased electrolytes, retention, urinary and constipation, infection and sepsis, uncontrolled pain, and medical conditions such as dementia and Parkinson's disease. So what are the types of delirium? So in the hospital setting, the person may already have a delirium when they're admitted to hospital, and this can be a distressing environment for the person and may exacerbate their symptoms. There are 3 different types of delirium. People with hypoactive delirium experience increased confusion and can feel agitated and restless. They have noticeable changes in their behaviour and can be paranoid and suspicious. Hypoactive delirium can often be missed, as the person may become more withdrawn, they become quiet and sleepy, and they may need support to eat and drink, and they may not want to engage in conversation. You can also have a mixed delirium, And this is a combination of both, and this can lead to mood changes over the course of the day. So looking at this slide, so as dementia progresses, it affects areas of the brain. So we'll just talk about dementia. So these images show a healthy brain on the left and a brain with severe Alzheimer's disease on the right. So we can think of the brain resembling a walnut with complex structures and blood vessels. The slide on the right shows blue dye running through the brain, and you can see how dementia has progressed. The blue areas on the brain show more spaces and left ventricles. Dementia can affect the person in many different ways, as it's not simply just progression or memory loss. So you can see on here that it affects the thinking, the moving, touching, hearing, their speech, their balance, information processing, taste, speaking, and emotion. So what is the relationship between delirium and dementia? So people with dementia are more at risk of developing a delirium. In those living with dementia, it's important to identify the cause, as discussed in the previous slide. Collateral history and gathering information from relatives and carer will help recognise and treat the underlying causes of delirium. However, sometimes delirium cannot be noticed or recognised in people living with dementia, but there are many causes of delirium, which can at times sometimes can make it difficult to diagnose, and delirium can be treated. However, in some cases, delirium can sadly have a poor outcome. So delirium can last days, weeks, or sometimes it can take months to recover. We know from previous slides that delirium can increase the risk of dementia. So delirium can also happen outside the hospital, and it is more common in those people who live in residential and nursing homes. It is estimated 1 in 4 care home residents may experience a delirium. So how do we distinguish delirium from dementia? So delirium starts suddenly over a period of 1 to 2 days, and symptoms often also vary a lot over the day. The symptoms of dementia come on slowly, over months or even years. So if changes or symptoms start suddenly, this suggests that a person may have a delirium. Dementia with Lewy body is an exception though, and this type of dementia has many of the symptoms as delirium, including visual hallucinations, and this can vary a lot over the day. So how can delirium affect the person? So they can become less aware of what's happening around them, be more confused at times, especially in the evenings or overnight, and this may be a new presentation for that person, unsure of where they are or who you are, sleeping in the day and staying awake at night, having vivid dreams that are often very frightening, see things people that are not there, think people are trying to hurt them, become agitated and restless and may start to pace or may start to wonder, be very slow or sleepy, hear voices or noises, and changing their moods very quickly. They may be unable to follow a conversation, whereas before they could follow a conversation. So we look at altered behaviour. And again, this just highlights on the previous slides the things that can affect the person living with dementia. And this may not just be in a hospital setting, this could be at home as well. And sometimes when a person with dementia delirium becomes distressed, it is often because they're trying to communicate something to you. You might see their behaviour change, and at these times they may become agitated, they may start to walk pace or walk with purpose, or may want to go home. They may become withdrawn and uncommunicative, which is something that they're not normally like. This is when we may need to start thinking about what they're trying to communicate with us. Have they got an unmet need? Are they anxious or frightened about something? Again, I'll talk to you about that they may be hallucinating, seeing things. Especially in the hospital environment, it is a scary place. It can be very, very busy. Are they uncomfortable, or if we are in hospital or a care home setting, are they disorientated? So we need to think about all of these things. Is this aggression new? Are they more tearful than normal? So how do we recognise delirium? So in the trust, we use the single question in delirium. Is the patient more confused or more withdrawn than normal? If you do think they are, then think delirium. And we know delirium is a medical emergency. So what assessments do we use? So within our trust, we diagnose delirium using the 4AT, and you can see that on this slide. They're very simple questions that we ask. We take the immediate action as necessary. So for example, if they're in retention, we would treat that. Identifying potential causes of delirium using the Think Delirium tool that I showed you at the beginning of the slide, and identify that type of delirium. We then go on to have a medical plan of the general management of that delirium, and once they're discharged, it's making sure that the GP knows that this person has got a delirium, because like we said previously, delirium can last up to 6 months, or this could be their new baseline. This enables the GP to be able to monitor them in the community. We go on to use the AMT10 test, and that records their baseline and cognition. Remember, delirium can affect capacity to consent to treatment, and it's essential that we consider a mental capacity assessment or Dole's assessment or a best interest. So what are the managements of a person living with dementia who has delirium? So we need to make sure we treat the hypoxia and electrolyte imbalance, treating sepsis, and manage their constipation. When did they last have their bowels open? What was the type of stool that they had? Was it a tight fall but only a little bit? Are they constipated? Do they need medication to help with that? Are they in urinary retention? Completing a bladder scan to monitor this, to rule this out, to see whether or not they are in urinary retention, and assess for pain. It is essential that we assess for a person's pain, and if that person living with dementia is unable to communicate, then we can use a tool called Cannot Verbally Express Pain, and this is part of the pain aid tool, and this helps you to identify the pain for that person without them able to communicate with you. So looking at their body language, to look for that. Review their medication. Is there medication that's contributing to this? And avoiding additional bed moves and ward transfers. We know that that is difficult in hospital, but making sure if we do move our patients, that we are moving them at early in the day, or if they are being transferred back to a care home, then making sure that they get to that care home early. Completing the Know Me Better patient summary, and this is something we use a lot in the trust, and this helps to support person-centred care with that patient. Making sure they've got their glasses on and their hearing aids in. If their hearing aids need batteries, making sure that their batteries are changed and it's working. Avoid distress, reassurance, making sure that patient's okay, and early mobilisation. Don't leave them in bed. Make sure that we're getting up in the day, support with them getting dressed so they know that it's daytime. Good sleep. This is sometimes very difficult in hospital, but when they're in the community, making sure that they are getting a good night's sleep and a good routine. Orientate them. So making sure they know that it's the daytime and it's not the night time. Here at UHL, we use orientation boards, and these have got the date on and the time, and it does help patients. Promote nutrition, making sure these patients are eating and drinking. offer finger foods, especially in the community. That may be something that now they'd rather eat. Milky drinks, making sure we're giving those in coloured cups or coloured plates to prompt them with it, and leaving it in reach. Inform and involve the family. Family find delirium extremely distressing, and there is lots of information leaflets. Dementia UK do an information leaflet about delirium. Here at UHL, we have our own information leaflet which we give to families. It can be incredibly distressing for them, and it will help them understand what is happening to their loved one. Also ensuring that families are able to visit so they can support with nutritional intake and make that patient feel safe in hospital. It's also essential out in the community as well. So if they are in a nursing home, care home, making sure that family are really involved in supporting that person. Reassess their cognition. This may fluctuate and change, and consider a DOLS and a mental capacity assessment. And refer, if needed, to the mental health liaison service if you feel that you need support with this person. So this is a case study. So this case study is a person that was referred to the Admiral Nurses, and his name was Ken. He was a 72-year-old male diagnosed with vascular dementia. He lives with his wife, has no package of care, and a sitting service 2 hours per week. He was admitted with COVID pneumonia, delirium, hyperkalemia, and an acute kidney injury, and a history of delirium on previous admissions. So he was prescribed benzodiazepines, and they were having to frequently use these on the ward due to his agitation. He had an IV infusion attempted for dehydration, but Ken was not compliant with this due to his delirium. He had a clinical frailty score of 6. So the Admiral Nurse referral received was support with clinical management and relationship-centred care. So a holistic nursing assessment was completed. So Ken was supported to put his glasses and hearing aids in place. During that assessment, he didn't have those on. This supported Ken to be aware of his surroundings and engage in conversations. So Ken's nutritional needs were not being met, and this was due to Ken not wanting to eat and drink. So Ken was supported with his own, and it was noticed that he had a coating on his tongue and he actually had oral thrush. So during his assessment, pain was really noted on movement. So we completed a pain assessment using the Cannot Verbally Express pain tool. So Ken was scoring a 5, indicating he needed his analgesia to be reviewed. So we found out through reading through his notes that Ken had actually had a fractured pubic rami in the past. We then discussed this with the medical team, and appropriate analgesia was prescribed to help Ken with this. We also noted that Ken had had a previous delirium, so this pain would have been contributing to his delirium. We also made a referral to the MAF service, so that's the Meaningful Activities service here within UHL, and they supported Ken with his cognitive stimulation and nutritional intake. Ken enjoyed music, so we have something called a Rita, and that's a computer that plays music for the patients, and Ken found a lot of enjoyment from this. We also contacted his wife, and she was unable to visit because during this period there was visiting restrictions. So Ken normally copes well at home, and although struggles with his memory, this behaviour described was out of character for Ken. So we were able to complete a patient profile, and what matters to me was completed. And there, the picture of those are on the previous slides. Ken's assessment was discussed and reviewed by the medical team. So we were able to start the analgesia, which helps Ken with his pain, and is also treated for his oral thrush. So all these things were contributors towards Ken's delirium, and he was also at high risk due to his vascular dementia and his delirium, and the fact that he had a COVID pneumonia. Once all these things were put into place, Ken was then able to engage in conversation. The ward staff understood that he probably needed analgesia before before any personal care or before any movements. And they were supported to use a cannot verbally express pain chart. So this helped Ken with his delirium symptoms. Sometimes simple things make a big difference. So why do we need to think about delirium? So everybody is at risk of delirium age over 65s, and they have a huge increased risk. So it's quite common and it is preventable. It's also treatable, but it's associated with real high risk of falls, pressure sores, a longer inpatient stays, and malnutrition and aspiration in our patients. And it is associated with a high risk of death. And it can be an extremely distressing experience for the person and their loved ones. So remember, is your patient more confused than normal? Then think delirium. If you're unsure, get your patient or resident or loved one reviewed. Thank you for listening, and I'm happy to answer any questions.